Thank you very much, Dr. Vize, for the kind introduction. Ladies and gentlemen, good morning. We already heard yesterday that there's no doubt that intensive care has improved significantly throughout the last decades, especially in terms of mortality. But there's another issue, and we already heard that yesterday as well, that patients who survive an episode of critical illness often suffer from functional and neuropsychological disabilities. And here you can see data from Martha Herridge, a study where they identified 4 different risk groups in terms of outcome based on age and ICU length of stay. And as you can see, especially in the elderly patient, after 1 year after critical illness, only approximately 35% of patients are at home. And this is because a lot of patients still suffer from persistent functional and neurocognitive disabilities. And for example, if you look at the physical disabilities, here again from the same studies, you can see here the middle-aged group in yellow and the red group. These are the elderly patient cohort group, and you can see that most of the patients after 6 months after critical illness still are dependent on maximal to total assistance in terms, for example, of bathing, stair locomotion, and dressing. When you look at the neuropsychological disabilities, you can see that this is more independent of age. So this is a study done by the Vanderbilt group. They included a patient with respiratory failure and shock, and they followed up the patient regarding neurocognitive functioning. They used the air bands. We already heard that yesterday, a neuropsychological test battery, and they could show that approximately 25% of the patient had significant cognitive disabilities 12 months after ICU discharge. And some of the patients, you can see that here, they had cognitive disabilities in the room of Alzheimer's disease. And this is really a big issue for the patient, but also increases healthcare costs. And what you can see also on this slide is that it was dependent on the duration of delirium, which is a sort of acute brain dysfunction. So the longer the delirium was, the more severe the cognitive dysfunction was. And as you know, delirium is very frequent, especially on the ICU. You can see here the prevalences of delirium and cognitive dysfunction in the perioperative context. So for example, if we have a patient who goes into surgery, then he will be treated after surgery on the ICU or in the recovery room, and we have here very high prevalences, up to 87% in mechanically ventilated patient, but even in the recovery room, 45%, and on the surgical ward, there are incidences reported of up to 21%. And the important thing is that patients who develop once delirium during their ICU stay, they have, after hospital discharge, up to 41% of cognitive disabilities. And that, of course, increases also healthcare costs. This is a secondary analysis. It's not limited to ICU patients, but rather patients who developed delirium during their hospital stay. You see here the annual healthcare costs associated with delirium after hospital discharge. It's from the US, and you can see that the costs associated with delirium are in the line, let's say, with very frequent diseases like diabetes or cardiovascular diseases. And that's, of course, one of the reasons why we should prevent delirium, because that probably lowers the risk for developing cognitive dysfunctions afterwards. And it turns out that one of the major risk factors for developing delirium is deep sedation. So there are some indicators from study. The first study I want to mention is the study from Shehabi. This was a prospective observational study, and they compared patients who were deeply or moderately sedated during the first 48 hours of ICU treatment with the group of patients, this is the red line here, who were not deeply or moderately sedated during the first 48 hours. And they could show that patients who had this early deeply or moderately sedation had a significantly higher risk for mortality within the first 6 months. And what they could also show is that 90% of patients who developed delirium during their ICU stay were in the group who received moderate or deeply sedation during the first 48 hours. So there seems to be a connection between sedation and delirium. And there are also other studies showing that at least iatrogenic induction of coma or deep sedation is independently associated with transitioning to delirium with an odds ratio of up to 3.2. And this might be one of the reasons why national and international guidelines are recommending to not sedate patients at all, even when they are very sick within the first 48 hours. For example, the German S3 guideline says that the critical ill patient should be awake and alert without pain, anxiety, or delirium. Ultimately, this allows the patient to actively participate in their treatment and recovery. So far, so good, but when it comes to a clinical practice, things are becoming more difficult, because this no sedation approach is often challenging, of course. So what we see is when we try to keep patients awake during severe illness and organ support, or when we're trying to wean them from sedation, we often see symptoms of agitation. And what we are doing then, often when we see the agitation, we apply sedatives to calm the patient down, to sedate the patient. But as we heard, sedation increases the risk for developing delirium. And delirium, of course, is often accompanied, for example, by hallucinations. And hallucinations, of course, increases the risk for anxiety and agitation. So we have some kind of vicious circle here, which is often hard to treat in the ICU. And we think that the ICU environment can play a key role to help to implement this no sedation approach. I think you saw this picture yesterday already. This is a picture from the patient's perspective from our ICU, and you can see if you wake up as a patient on the ICU, it makes you anxious. You are surrounded by different kinds of machinery which make noise. Sometimes you think they work not properly, you don't know what the alarms mean. You almost have no daylight here, you don't know where you are, and you have a very high sound pressure level, so noise in the ICU. So you can imagine that you get anxious. So and that's maybe one of the reasons why we have to apply some kind of sedation, which is part of the problem we have clinically on our ICUs. And so that's why we thought about designing an ICU room more from the patient's perspective. So having a room design which is more stress relieving, which allows us as clinicians to better implement this new sedation approach, which is recommended in our guidelines. And you also saw this picture already yesterday. You can see this is the same room, and you can see that the patient perspective changed completely. So we tried to eliminate a lot of the medical equipment from the patient's point of view. We have this sideboard-like partitions so that there is some kind of privacy even when the patient is treated in a two-bed room. And we eliminated these technical equipment by designing this technical corridor here. So this allows us to store a lot of medical equipment behind the patient, so eliminating it from the patient's point of view. For example, the syringe pumps, the ventilator is stored behind this wooden wall, so that when the patient wakes up, it looks more like a more private and stress-relieving room and atmosphere. Despite this more, let's say, nice environment, we aimed to support sufficient sleep in the ICU, because that is a real issue on the ICU. We know that from a lot of studies. And this is probably related to high noise levels on the ICU and insufficient lighting conditions. You probably all know that the gold standard for measuring sleep quality is the polysomnography. And you can see here a polysomnogram of a healthy adult. You can see this healthy adult has all the different sleep phases, so also deep sleep phases, stadium 3 and 4, and the patient also has rapid eye movement sleep. So this is like a very normal, healthy polysomnogram. The patient slept approximately 7 hours and had a sleep efficiency index of over 90%. So this is what we want to have also on the ICU. The question is, why is sleep quality or an efficient sleep quality so important for cognitive functioning? Or why do we believe that making the sleep of our ICU patients better will decrease the risk for developing delirium and cognitive dysfunctions? The glymphatic system might be one of the underlying mechanisms which has been discovered recently. So the glymphatic system is, let's say, a sort of a macroscopic waste clearance system. And on this figure here, you can see the microvascular unit in the brain. And the microvascular unit in the brain allows a bidirectional communication between the microvascular unit and the neurons. And so the cerebrospinal fluid and the interstitial fluid continuous interchange. And this interchange is facilitated by a convective influx of the cerebrospinal fluid along the periarterial space. And so when the CSF movement into the parenchyma drives the interstitial convective fluid flux in the tissue through the perivenous space, and thereby flushing out toxic molecules, like, for example, alpha amyloid beta, which is associated with neurodegenerative diseases. And the interesting thing is that this process, this interstitial clearance, is facilitated or is mostly happening during sleep, which you can see this very nicely here. So here you have on the left side a mouse during sleep, and the same mouse when it is awake. And what you can nicely see here, that during sleep the perivascular space really opens up. And this sort of enhances the interstitial clearance in the brain. Coming back to our ICU patients, we have the problem that most of our patients are not really sleeping, or let's say in other words, the sleep quality is very bad. So this is a polysomnogram of one of our patients post-operatively after major abdominal surgery. The patient at this time was not sedated and not mechanically ventilated, and you can see the polysomnogram looks completely different. So we have almost no deep sleep phases and no rapid eye movement sleep. So the patient slept twice as much as the healthy adult, but sleep efficiency index was very bad, so below 70%. And that's actually the problem we are facing. And this probably has to do with the noise levels on the ICU. As you may know, the WHO guideline recommends noise levels or median sound pressure of 40 decibels in rooms where patients are treated. But it's completely different on the ICU. So all the studies, they measured mean sound pressure levels of 83 and above. So this is like trying to sleep on a highway. It's not possible to get sufficient sleep. And that's why we tried in our rebuilding process to build an infrastructure that helps to reduce the noise in the rooms. So here you can see a sketch of the standard and the modified room, and highlighted are the different noise categories we identified. So the one category, it's associated with medical equipment, and you can see that we tried to, in the modified rooms, the medical equipment is stored more behind the patient, behind sound absorbing wooden walls. We also reduced the working places in the patient rooms by creating we call it an observation room, which allows, especially in the night, that a lot of work can also be done in the observation room, but at the same time, nurses can see the patient, and the patient can see the nurse and the physicians. And the main entrance is not this big door here. The main entrance is now through the observation room. So the traffic has also changed. So we have automatic closing doors here, and the traffic is here through the observation room. And after this rebuilding process, we did sound recordings over 3 months, comparing standard and modified rooms. And in this study, we only compared sound pressure levels between rooms where, let's say, the severity of illness of patients treated in the rooms was the same, because in terms of noise, this makes a huge difference. This is the first time that this was done in a study, and we also compared only sound pressure levels when the medical equipment used in the rooms was also the same, because that makes also a difference. So is the patient mechanically ventilated, yes or no? Do you have an extracorporeal membrane oxygenation, etc., etc.? So this makes a huge difference, and on this graph you can see a little piece of the results. Here you can see the mean sound pressure levels of one night. Standard room, modified room. And as you can see, we could reduce, especially in the night, mean sound pressure levels by up to 10 decibels. This is more, so we halved the loudness for patients treated in the room. And this was observable in every night. So this is just one night to show you. And more importantly, we could also reduce the threshold overruns. That's maybe even more important, because when you have a sound peak, that awakes the patient. So this could be shown also in experimental studies in healthy adults. And here you can see the same night, the threshold overruns over 60 decibels and under 60 decibel. And you can see that those threshold overruns greater 60 decibels could be reduced by more than 50%. So it seems that the, let's say, noise environment has improved with this new design. We have to see if that will have an impact on patients' outcome, of course. The second point I want to make is light. So the light environment in terms of the circadian rhythm and sleep plays an important role, of course. This graphic just summarizes why it is so important. So light is the most important stimulus for keeping the circadian rhythm on track, or for entraining patients to the circadian rhythm. So the light perceived by photoreceptors in the retina, this signal will be transduced by the tractus retinohypothalamicus in the suprachiasmatic nucleus, and then will suppress the production of melatonin. And of course, this is guiding our sleep, and probably has also, as I said before, impact on the delirium incidence, and probably also on long-term cognition. And when we look, for example, at the melatonin levels, the circadian melatonin levels, we have some studies already. This is one study done in post-operative patients on the ICU. And you can see here the dark curve. This shows you the normal circadian melatonin pattern. So you have a nocturnal rise of melatonin, and the curve flattens when it comes to the morning. And what the authors saw here is two different kind of patterns when in patients who develop delirium. So the one group were patients so these are patients who had post-operative delirium, and you can see they don't have this nocturnal rise of melatonin. But there was another group of patients, which you can see here, and these were patients with delirium who developed post-operative complications. And those patients had very, very high melatonin levels. So there's still a circadian rhythm, but all the melatonin levels are very, very high. So, and this is probably an explanation why, let's say, studies, randomized control studies, treating patients with melatonin showed inconsistent results, because we have different patients and different problems in those patients. So, and especially for those patients who have this high melatonin levels, it would be obvious to use light as a treatment to sort of take them back to the normal circadian rhythm. And what would be more obvious than using light, natural light coming from the window? But the problem is, so in our ICU, we also have a large window area, approximately 11 square meters. But the problem is that even if you have sufficient light at the window, that doesn't mean that you have sufficient illuminance at the patient's eye. So this is one study showing this very nicely. So if you measure the light directly in front of the window, you have approximately 600 lux, which is not bad, but at 2 meters, you can see that the illuminance drops dramatically. So you only have approximately 150 lux. And this is not enough to have a biological effectiveness in terms of, for example, melatonin suppression. It won't work. So that's why probably it's good to have artificial lighting if you want to use light as a treatment for patients. And that is exactly what the colleagues from Siemens in the Netherlands did. They did a randomized controlled trial where they compared patients who received dynamic lighting treatment compared to patients who received normal lighting conditions. And here you can see the lighting schedule, the purple curve here, and you can see that patient received a maximum between, let's say, 600 and 800 lux. We installed the same lighting tubes, which were fluorescence tubes, on our ICU, and together with colleagues from the Technical University in Berlin, we calculated circadian effective irradiance and compared those values with thresholds for maximal melatonin suppression, which we gathered from elderly patients, healthy elderly patients. And we measured or calculated the circadian effective irradiance at the patient's eye level. One situation when the patient lies flat in bed, and the other situation when the patient hasn't had a bed elevation of 35 degrees. So this is a situation when the patient looks directly into the lamp. And what you can see is if you use this sort of lighting, we had it in our situation it was slightly higher, so between 500 and 930 lux. You can see they are inconsistent in results. So in some patients, you are above the threshold for maximal melatonin suppression, in some are not. But if the patient looks directly into the lamp, you definitely will get melatonin suppression if the patient looks into the light for at least 1 hour, because that's something we did with the healthy adults here, where the threshold comes from. But if you consider illuminance, you also have to consider the luminance, because if you apply high illuminance, it may come to glaring effects. And that is exactly what is happening here. So what we saw when we were measuring the luminance for this sort of lighting, we saw that when the patients try to look into the lamp, you will exceed the threshold for absolute glare. So it's not possible to look into the light. So what I assume is that the patients in the study here probably were too much sedated, so the eyes were closed probably. That's something the authors discussed in the study as well. Or they were wearing sleep masks or something. You can try it, it's not possible. And that is the reason, this may be one of the reasons for the negative results in this study, and it's also the reason why we developed this large light ceiling in the new rooms. So you have an area of 15 square meters, and you have 2 different kind of LED lighting. So the lighting here in the middle of the screen, these are high efficiency LEDs, and in addition we have RGB LEDs, which can show you moving colored objects, let's say. That's how it looks in reality, and we did these measurements for circadian effective irradiance again, and the results are shown here. So here again, you see the circadian effective irradiance. Here again for the fluorescent tubes, which were also used in the Simmons study, and here for the new light seeding. And as you can see, no matter in what position the patient is, the circadian effective irradiance clearly exceeds the threshold needed for the maximal melatonin suppression. And more importantly, if you look at the luminance levels, you can see for the new LED seeding, we have very, very high luminance levels, so up to 2,750 lux, which is much more than in the Simmons study, but in the same time, we are not exceeding the threshold for absolute glare compared to the other system. So this is maybe, we have now the technical possibilities to apply high illuminance levels without glaring the patient. And this is a first step to, let's say, designing lighting therapy for for later randomized controlled trials. Of course, you can do a lot of other things also with the light ceiling. As you maybe heard before, we have these RGB LEDs, which can you show moving objects, which all have a different, let's say, function. So we designed these layers, let's say, to support the healing process. So the basic layer is always the sky and the sun. These visuals are related to real-time conditions depending on the geolocation, and it's also connected to real-time weather data. So somehow bring the sky, the real world, to the patient, and it should help the patient with the reorientation process. And this is also done with a lot of other layers, which you can see here. And instead of playing back pre-recorded animation, all these visuals are parameterized in real time depending on the patient's condition. So what we did is we designed a tablet app. This is a tablet app which is work in progress, let's say, which will be available in German, English, and Dutch language by the middle of this year. And here you can see, for example, the item vocalization for the behavioral pain scale for non-intubated patients. And depending on the input here, for example, the layer of green leaves will be parameterized. So we are using green leaves for pain reduction. There is some evidence that the association with greenery helps patients, especially in the post-operative period, to reduce the need for analgesics, for example. So let's say the higher the pain score, for example, the more time the patient will see the greenery per hour, and the more leaves the patient will see. And there are other parameterization processes. For example, if the patient has hallucination or delirium, for example, everything on the screen will be static because we don't want to induce hallucination. So if the patient sees moving objects, that's maybe not a good thing. So this is just an example of what we mean by real parameterization. So currently, we are doing a first observational trial, which is still running. So we are still waiting for 5 patients going into the study protocol. And we are collecting a lot of clinical data. Delirium incidence is the primary endpoint, but we're also having this a maximum of 3 series of measurements where we're doing a polysomnogram, we are collecting melatonin and cortisol, and also clock genes. So this study probably will give us a better idea what's going on in our patient and to better design future randomized controlled trials. Because we have a lot of opportunities, of course, now, but there's still a lack of, for example, if you're looking at the lighting therapy, what is adequate for the patient? So I think we still have to learn from observational data and also from basic studies and experimental studies to better tailor these interventions to have a good starting point for randomized controlled trials. But we truly believe that the ICU environment can really help us to, let's say, have more of these awake patients to make it easier for the clinician to implement the no sedation strategy. Here are some examples, and we hope at the end that this will lead to an improved outcome for our patients. Thank you for your attention. Happy to take questions.
Yeah, thank you very much for this exciting project and interesting data. We have time for 2 questions. Please. May you?
I have a comment. As I learned yesterday, you have 4 of these very exciting beds in the ICU. So in the other beds, the patients are in the unfortunate situation that they don't have this very nice environment. Right. So when I listened to you, I thought that there are headphones available on the market, which are actively depress outside noise by just reversing the phase of the incoming noise. So you could actually silence this noise for rather little money. And at the same time, you could play Mozart. And probably that would help the patients too.
Yeah, it probably would help some of the patients. The problem, I think, is when working with headphones is that you really have to be sure that somebody is observing the patient, or the patient has the possibility to take the headphones off again. If that's the case, I think to have sessions to provide those headphones for the patients could also be a good thing. But I think it can also be harmful for the patient if you, let's say, just giving the patient the headphones and leaving him alone. Because, of course, this is also a sort of sensory deprivation, which also can lead, for example, to anxiety and so. So I think this is a possibility, but not for all patients.
Short question, do you have already a feedback from the patients themselves?
Yes, we do have, of course, feedback from patients and also from relatives. It's especially interesting when you ask patients who were in a standard room before and then coming back to the ICU in these new modified rooms. And what most patients are saying, that is much more quiet. This seems to be something which is really perceived by the patients. And what we also see is, so we also looked also on the data we have so far, and what we see is that patients are more calm, so we need less sedatives. This is a tendency what we see, which is an indicator that the rooms helps probably to get this no sedation approach better implemented in more patients than without the room. So the infrastructure maybe can really help to achieve that. So we have to wait if the data are complete, but that's a tendency we see.